Professor Kim, Wang is the first speaker.
The presentation coming, but it's very slowly.
Hello?
Yes.
Only it's your turn.
Yes,
now.
okay. Good morning, good afternoon, good evening, everyone. Welcome to our third SIGVARIS Medical Online Hub webinar, Asia Pacific. The topics will be very interesting: venous disease and compression therapy. May I introduce myself and our colleague? My name is Zhan Zhou, responsible for the business in Asia Pacific. My colleague, Eric, he is our sales manager for all the region. Now, I give you the indication. If you want the Chinese language for this webinar, please, you can put the bottle on your control board, the down right side. 如果说你们是要用汉语讲清，那你就用这个键盘的右下方键，这个你的语言是选择汉语就可以，是英语的就不用。Now I give the words to my colleague Eric, please.
Thank you very much, Johnny. Ladies and gentlemen, a warm welcome also from my side. It is one of SIGVARIS' big tasks to spread medical knowledge about compression therapy and share it with the world. Today, we are very proud to have top specialists with us as moderators, speakers, and panelists. We are sure together with you all, this is going to be a very interesting 2 hours for all of us. Now I'd like to introduce you to the moderators. Professor Dr. Dong-Ik Kim, Division of Vascular Surgery, Samsung Medical Center. He is Vice President of Union International of Phlebology. He is also Vice President of Korean Society of Vascular Surgery. Then Professor Dr. Shen-Min Wang, Division of Vascular Surgery, the first affiliated hospital, Sun Yat-sen University. He is President of Chinese Association of Phlebology, and he's also Vice President of the Asian Venous Forum. These two gentlemen, with their long experience and great knowledge, will now lead you through this meeting, and no doubt they will do a very, very good job. Please now, Professor Wang, can you start introducing the panelists? Thank you very much and enjoy the meeting.
Okay, his connection does not work. I will see Professor Kim, can you take the role?
Okay, thank you. Thank you, Eric, for nice presentation. Ladies and gentlemen, we have 6 panelists for today's webinar. So from now on, I will introduce 6 panelists one by one briefly. First, Dr. Mark Maloff, my old friend. Good afternoon, Dr. Mark. Yeah, he is a surgeon in phlebology practiced in Sydney, Australia. He was president of Australian and the New Zealand Society of Phlebology, and he was vice president was UIP in the past. He has experienced lots of sclerotherapy, thermal ablation, phlebectomy, and management of leg ulcer and venous thromboembolism. Mark, I look forward to asking a good comment today. Second, Dr. Tomio Ogawa, my friend of Japanese. Hello, Dr. Ogawa.
Hello.
He was the vice president of Japanese Society of Phlebology, and currently he is vice president of Asian Venous Forum. He is one of the most active phlebologists in Japan. Currently, he is a director of vascular surgery in Fukushima Medical University Hospital, Japan. Also, I look forward to asking a good comment today. Next, Dr. Fuxian Zhang, my friend of China. Nice to see you again, Dr. Chang. I have been known him for several years, and I know he is a very excellent senior member of vascular surgery group in China. Currently, he is a vice chairman of vascular surgery committee and the chairman of expert committee of venous thromboembolism of the Chinese Medical Association. Currently, he is a chief physician, professors with the tutor of doctoral student of Beijing University and Capital Medical University, chief of major surgery of Beijing Sijitan Hospital, director of vascular lymphatic surgery center. And also, I look forward to asking a good comment today. And next, Dr. Sun Sen from Taiwan. Hello, Dr. Sun. Yeah.
Hello. Good afternoon.
Yeah, he is a surgeon of cardiac and vascular surgery. He is interested in venous PTA and stenting, varicose vein surgery, and DVT treatment. Currently, he is working in Mackay Memorial Hospital in Taiwan. Also, I look forward to asking a good comment today. And next, Dr. Takashi Yamaki. Actually, he is a plastic and reconstructive surgery, and currently he is a professor of Department of Plastic and Reconstructive Surgery. Also, I look forward to asking a good comment today. And finally, Dr. Jang Young Kim from Korea. Hello, Dr. Kim. Actually, he did his vascular surgery fellowship under me for 2 years, and he is one of the most active middle-aged vascular surgeon in Korea. Currently, he is a staff of the Catholic University of Korea. Also, I look forward to comment. Okay, thank you. Okay, I finished my introduction for panelists.
Thank you very much, Professor Kim. I think we would then start with the first
speech,
but it seems to be that Professor Wang is not available. So I think we should then start with the presentation of Dr. Mo. So Professor Kim, could you introduce Professor Mo to the audience?
Yeah. Okay, and now let's start today's presentation. First, I will introduce our first speaker, Dr. Mo, briefly. He graduated the Gunma University School of Medicine in 1984, and currently he is a clinical professor, Yokohama City University School of Medicine, director of Japanese Society of Phlebology, and counselors of Japanese Society of Vascular Surgery. He attended to guidelines for the management of arterial occlusive disease, guidelines for the management of venous thromboembolism, and guidelines for endovascular ablation for varicose vein, 2019. He is interested in compression therapy and hosted compression and medical elastic stocking hands-on course of Japanese Society of Phlebology 8 times per year since 1998. Currently, he is a director of Japanese Society of Phlebology. Today, he will give us a talk about acute deep vein thrombosis and compression therapy. Dr. Mo, please.
Thank you very much for kind introduction for me, Dr. Kim. Nice meeting you. So I'd like to discuss with you compression therapy and acute DVT. So I'm going to share my screen with you. Can you see my screen?
Yes.
Okay,
Yes.
so can you see my screen? May I start my
Perfect.
So I will start my presentation. The title
Yeah,
is Acute DVT and the Compression Therapy. And at first, I like to talk about the prophylaxis of the DVT for surgical patient. And of course, surgery causes DVT and pulmonary embolism. This is a serious problem. And Cochrane review of 2018, more than 20 trial or surgical patients demonstrate much lower rate of the deep vein thrombosis in patients with compression stocking. But most of the study, the problem is that most of the study is old, and it was before 2000 year. And after that, there is a clot trial. This is a study of the patient with stroke. And with compression stocking, there's no benefit, the BT reduction. And instead of that, it increased the skin trouble with compression therapy. So this is very disappointed result for compression therapists right now. But after that, the clot-free trial was demonstrate IPC, the same as compression therapy, is effective method of reducing risk of DVT in stroke patients. So even though the patient cannot move, the compression therapy is effective. And we have, it's about 5 or 7 years ago, it's a large meta-analysis. It's a huge meta-analysis. It was published in AHA, and it is effect of the IPC on the risk of the pulmonary embolism compared with no IPC. Oh. No IPC. And of course, IPC is better than no IPC. So, and second study is effect of IPC on the risk of DVT compared with no IPC. And of course, IPC is better than nothing. And also, it analyzed effect of IPC on the risk of DVT and the pulmonary embolism and the bleeding and the complication and the mortality compared with pharmacological thromboprophylaxis, so anticoagulant. And in terms of bleeding, of course, IPC is better. So no much of the bleeding with IPC only. And the effect is surprisingly, it's almost same. And compared to pharmacological thromboprophylaxis. Actually, this result is almost same as Japanese experience. Probably in Europe or America, a lot of the people use a pharmacological thromboprophylaxis instead of compression therapy. And additional benefit of compression therapy stocking to the pharmacological thromboprophylaxis is a question in systematic review. It's a huge, a lot of systematic review, and one of the study is a direct comparison between the with and without compression therapy. It showed negative study on compression study. And just recently, we are very shocked with our GAPS study. It is a study graduate compression stocking as adjunctive to pharmacothrombophlebitis in elective surgical patient. It is RCT about 2,000 patient in the moderate on the high risk patient. It compared as intervention group is a low molecular weight heparin injection only. And the control group is a low molecular weight heparin and the compression stocking. And the rate of the VTE is 1.7% in injection group and 1.4% injection and the compression stocking group. So actually this reached the non-inferiority. So this study showed administration of the pharmacoprophylaxis alone is non-inferior to combination of the pharmacoprophylaxis and compression stocking. But we have to know about this is a limited condition when the pharmacoprophylaxis is administered with very low VTE incidence. VTE incidence is just 1.4 or 1.7%. In this condition, it's very difficult to show the difference. So this study did not deny effective the compression therapy itself. This is my opinion. And I like to show the Japanese experience. And we have a social insurance coverage of mechanical prophylaxis was happened in about 20 years ago. And it demonstrates compression therapy is effective for prevention of VTE. Japanese guideline was published in 2004. And it recommended compression stocking and IPC for prevention of VTE. And because of that, Japanese social medical insurance coverage covered mechanical prophylaxis. So reimbursement was started. And on the other hand, in Japan, we have study of the pharmacological prophylaxis. Enoxaparin is tested in Japanese patient. The bleeding rate is about 4%. Major bleeding is 0.6%. Fundaparinox was also tested, and the bleeding rate is 44%, and the major bleeding is 0.31%. So because of bleeding, mechanical prophylaxis is mainstay of the VTE prophylaxis in Japan now. So this is a trend. At the year of 2004, mechanical prophylaxis is approved in Japanese medical insurance system. So, and mechanical prophylaxis increased sharply. And the pharmacological prophylaxis increased just gradually, slow and slow. And we have a nationwide, we have nationwide survey to check the incidence of pulmonary embolism. And this is the year the mechanical prophylaxis started. Okay, compression therapy started. And the rate of the incidence of the PE sharply decreased by half, only in 2-3 years, and keep about half after that, even the development of the CT scan. So actually, I think this is a trend is decreasing with development of the compression therapy. This is one of the proof compression therapy itself is very effective for prevention of the VTE. And the fertility rate is a little bit increased just after, but later decrease gradually. Of course, compression therapy and mechanical prophylaxis has a side effect. Arterial insufficiency may cause necrosis or the compartment syndrome, of course, nerve injury. And the most commonly, medical device-related pressures, skin trouble is most common. But this is minor, this is not a major problem, and we can handle this complication with care. And in Japan, we have a seminar for compression therapy, so-called elastic stocking and compression therapy conductor. We qualify the doctor, the nurses, and more than 3,000 people, nurse and MD are qualified in this qualification system after education. And we have official text, we have official textbook about the compression stocking and the compression therapy. And we have a hands-on seminar of the elastic stocking compression, how to wear, how to choose, and also how to wrap the bandage. Actually, we measure pressure of the actual sub-bandage pressure during the seminar. So this is a very good system to educate and spread the knowledge of the compression therapy in Japan. And the conclusion from Japanese experience is the mechanical prophylaxis of the BTE without pharmacological prevention is effective. And the complication of the compression therapy is preventable by education of the patient and medical staff. For example, elastic stocking conductor might be this system is very useful for system for the compression therapy. Then I like to talk about the treatment of acute DVT. At first, in acute phase, the compression therapy is good for acute phase. And the 5 of the randomized control trial few of the randomized control trial, compression and working versus bedrest. And this study shows compression stocking, the rate of resolution of the pain and the swelling and the thrombus is significantly faster when the patient ambulates with compression. This is a stocking, this is a thrombus resolution. So thrombus lengths become much smaller with compression and walking. And this is also Dr. Persh study, and he evaluate QOL and pain and edema between the bedrest and the compression therapy. And the bandage and the stocking and everything is good compared to the bedrest. But after this study, the SOX trial, sub-analysis acute DVT demonstrate it has no difference in the pain score. So from this study, we have to say elastic stocking cannot be recommended for the old patient routinely. But because of SOX trial, it downgraded the guideline in Japan too. And I had this 48 years old DVT patient referred from other hospital. And this patient had a CDT by urokinase twice. There was some improvement in the vein, but the patient did not get no compression at all because they misread the guideline. They think compression therapy is unuseful. And he is transferred for surgical treatment, and he could not work due to the pain. But actually, and what I did is initial decongestant therapy. And we ask a patient to ambulate with 2-layer short stretch bandage is a higher pressure, 45 millimeter, and then change to the compression stocking for 30 to 40 Hg high grade compression stocking. And the pain improved to the pain level 1. And look at this leg, just with compression, we have a very good result. So this is a real clinic. And after that, ideal study was published, ideal DVT study published, and the immediate compression after DVT associated with a significant reduction of residual venous obstruction, which is the same result as Dr. Porsche, 20% absolute reduction of the residual vein obstruction, and also 8% of absolute reduction of the post-thrombotic syndrome at the 2 years. So acute phase, we should put the patient on the compression therapy. And also, this is the sub-study of the ideal study. And with compression, edema, and the skin induration, hyperpigmentation, vein dilation is decreased with compression. So compression therapy for acute phase, currently, because RCT, routine use of the compression therapy is not recommended, but currently, what we have to do is try on compression at first and to continue wearing compression stocking if effective is a very practical approach. That is what I'm doing right now. And also, compression therapy is important for the post-thrombotic syndrome prevention. And we have 5 of the randomized control trial compare PTS occurrence. And one of the study demonstrate compression stocking to wear for 2 years decrease the PTS by half, 49%, 25. And second study also demonstrate compression stocking reduce the PTS rate by 50%. But after that, we have a SOX trial. And it says PTS is a PTS evaluated Bilarter score and the Ginsburg criteria. And this study showed there is no difference. Compression stocking do not work for PTS prevention. What's wrong with this? And is there any problem with the SOX trial? And this is a, sorry. And the delayed, actually in this study, the stockings made to the patient in the delayed period, not acute phase. So they use a compression stocking 7 days to 14 days later. And the compliance is very low because the patient did not get any instruction how to use a compression stocking. And also actually low-grade placebo stocking could have effect on the edema and the inflammation. And also, if the Barretta scale is correct, that is one of the other big problems. And after SOX trial, Octiva trial was published. This compare compression stocking for 1 year and 2 years, and a very high compliance, 84 to 96.4%. And the 1 year compression stocking, PTS is a about 20%. For 2 years, 13%. 13%. This is actually non-inferiority was reached, so it demonstrates compression stocking is effective. And the Cochrane review is after this study, recommend even though with low quality evidence, but support the use of compression stocking for prevention of post-thrombotic syndrome. After this study, real ideal PTS study was published. This ideal DVT study demonstrates individual therapy with compression therapy for PTS prevention is non-inferior to standard duration, 2-year duration of the therapy. What they did is if the Ginsburg's Barretta score is less than 5, they stop compression stocking. So this is the individual duration. More than half of the patients stopped compression stocking during study period. And these groups are compared to 2 years duration. And actually there is no difference in incidence of PTS. So individualizing the duration of the wearing stocking is effective and it could shorten the length of therapy needed and potentially it attribute to patient well-being and also cost effective too. So practically what we have to do is the prevention of the PTS is currently try on compression stocking at first and continue wearing compression stocking If PTS syndrome, like leg swelling and the pain persists, as long as it persists, and we ask a patient to wear it. I think this is a very practical approach. Thank you very much for attention. Sorry.
Dr. Mo,
Yes.
I have here a question came in from Paraguay, from Victor Canata. And he asks, did you use some scale to use the prophylaxis like Caprini score, or how do you decide who will use or who will not use the compression therapy? Great talk. Regards from Paraguay.
I see. Thank you very much for the question. Actually, we don't use for the compression because the compression therapy is a low complication. Generally, we try to use almost all patients early ambulation and the compression therapy. And that depends on we think the patient is a high risk for the VTE, we add pharmacological prevention. So we do not use we do not use a score for indication of the compression therapy.
Okay. Professor Victor Canata, my best friend of Paraguay in Latin America, quite a long distance from Asia. Thank you, my friend, Dr. Victor Canata, from your participant.
Yeah, thank you very much.
Anyway, thanks to Dr. Mo for your excellent talk. Ladies and gentlemen, before we open for discussion, we will conduct survey of one polling question related to this topic. Okay, now you can see the polling question on your computer screen. The polling question is...
This is a long question. This is not my question.
Yeah.
Khalid, this is a second. Khalid?
Because we switched, yes.
Yes.
This is
yes,
right.
Yes, is your question, yes.
Okay.
Yeah.
So, this is a polling question? Okay.
Yes.
The polling question is, how do you use compression therapy for prevention of venous thromboembolism? There are 4 possible answers as shown on the screen. Number 1 is always. Number 2 is only for high-risk patient. Number 3 is when pharmacoprophylaxis is not used. The final number 4 is none. Now, ladies and gentlemen, you can choose one of the answer from the lists on your screen. So we will give you 10 seconds for your answer for this polling question. Please enter the number of your answer on your computer screen. Now, let's start. We'll give you 10 seconds. Good. Thank you for your cooperation. Good. Now we will finish. We will close the survey. Thank you for your cooperation. The result is the majority answer is always. So, Dr. Mo, what is your recommendable duration, recommendable answer for this question?
I think I usually, most of the patients, I use a compression therapy. And during admission to the hospital, I recommend to use it. And this is for the prevention, yes.
Yes, thank you.
This is actually compression therapy is very low risk, yes.
Okay, thank you. Now, ladies and gentlemen, we will open for discussion for this topic. I'm sorry.
I think I have a...
yeah.
Yes.
So if there is any question or comments from participant, please send us a message with your name and country, and then we will ask question for you. During collection the question from the participant, we will invite two panelists to ask a question or comment for this topic. Dr. Sen-sun and Dr. Tomohiro Ogawa. So first, Dr. Sen-sun, please give your comment or answer, please.
Okay, thank you. First of all, thank you. The great speech from the Dr. Mo. Yes, I have a question about the popular problem during our daily practice. We have some patients with very high level deep vein thrombosis with very severe swelling over their thigh and the legs, and too swelling to wear the compression stocking. So how do you start to manage this problem? With elastic bandage or any other treatment before the compression stocking?
I think I usually start with a bandage, and bandage is at first I try to use a comfortable long stretch bandage if the patient cannot tolerate, and then change to the short stretch bandage, which is uncomfortable but more effective to reduce the edema, and then change to the compression stocking. But if the patient cannot use bandage, recently I use wrap garment, Velcro wrap for the patient who has a weak hand. And I also ask a patient family or care provider to help the compression therapy. Recently, we have a lot of the older patients. Some people cannot manage compression therapy by themselves. So we are still nursing home nurse and the family, and we teach how to use a compression therapy. That is what
because it is very difficult to manage the pressure given by the compression bandage. So how do you monitor the pressure of the bandage?
And actually, we have before we have pressure monitor, and I ask a patient to practice with that. But recently, we have a indicator bandage with indicator pressure indicator, and some of the I think there is kind of the indicator pressure indicator bandage, so we can we know with the indicator how much we have to stretch, and we overlap by half or by 2/3. We can change the pressure 30 to 40. That is actually very useful for us, because not only for the nurses, but also even family or patient himself can control the pressure by themselves. And the compression therapy is a kind of medicine. Dosage of the pressure is very important. So this is a very good question, and this is a very innovative thing. And the compression wrap have Velcro wrap also has some pressure indicator. That is very useful too.
Okay, I have another question. It's about the patient have DVT with arterial insufficiency. Sometimes we treat this patient only just with anticoagulant, because we know the compression stocking or elastic bandage may jeopardize to the distal perfusion. So how do you manage the patient have DVT as at the same time they have the PAOD, peripheral artery disease? Thank you.
If the patient has suspicion of the arterial insufficiency, I don't use a compression therapy, just medication at first. And if the patient cannot resolve with that, because I'm a surgeon, I usually perform thrombectomy. But of course, CDT is one of the choice. And but usually, even though in very acute phase, the leg elevation and anticoagulation in I think in half day or something like that, usually arterial perfusion come back. So the rate of the thrombectomy or CDT is pretty low in my practice.
Thank you
Thank
very
you,
much.
Dr. Sun. Very important question, and thank you, Dr. Mo, very clear answer. And I also invite the second panelist, Dr. Ogawa from Japan. Dr. Ogawa, go ahead, please.
Thank you very much. Very informative lecture from Dr. Mo. And I know that you are the Japanese teacher of the compression therapy for venous disease. I have two questions about your lecture. One is concerned about compression therapy for the prevention of the VTE. According to some of the paper, paralyzed patient or some of the immobilized patient cannot be useful for the using compression therapy because they cannot use that leg movement. So do you think that is it for this patient? What is your recommendation for the prevention of the VTE?
I think you are talking about cross trial on the stroke patient. Yeah, stroke patient, there is no effect on the VTE prophylaxis because those patient is a bedless patient for at least 1 week and they cannot move. So in this patient, according to CROT3 trial, I think IPC is recommendable. And probably it's the same. If a patient cannot move at all, compression stocking is not very useful. So I think IPC is more recommendable.
Thank you. Another question about the compliance of the using the elastic stocking for the chronic venous disease. We have several patients with venous leg ulcer, and I recommend that them to use wear the stocking for the long time. But some of the patients cannot wear a stocking all day except at the night time. And how do you recommend me to a patient who can wear the stocking well?
I think stocking, elastic stocking itself is sometimes it's very difficult for patient. I recently use, if the compression stocking, I use a longer stretch material, and thicker and like a towel compression stocking. But if the patient hand is not good, I think a compression stocking is almost impossible. In that case, compression bandage with a long stretch or soft cotton long stretch bandage is much more comfortable for them. And also, vertical wrap is one of the choice because we can adjust the pressure. And actually, for if we use a long time, it is not expensive anymore. Compression bandage, we have to change it every 2 months or something like that. It can be very expensive. So, but the key is just listen to the patient and spend some time with the patient. For example, Dr. Ogawa, you are very busy. You cannot do that. So I usually ask my nurse who have a qualification of the compression therapy. I ask them to listen to them and talk to them and let them choose what is the best thing to do. I think to spend the time with the patient is the key of the compliance and adherence.
Okay, thank you very much.
Thank you, Dr. Ogawa. Dr. Mo, there is some question from the participant. First one is, how do you check the amount of compression? It means 2 liters is as bad as too much. So how do you check the amount of compression?
In the case of the, you mean the pressure itself? If if the compression stocking, like SIGVARIS, if you size correctly, the amount of the pressure is predetermined. So it's very easy. But if we use a compression bandage, depends on the who performed the bandaging, the pressure is various. So they need training for that. But the solution is just, I think, a bandage with indicator is very easy to use, even for the nurse or even for the patient. It is very easy to use. And also, from the patient point of view, if they cannot use and it's too tight, even though patient is, we know the higher pressure is better, more stiffer material is better. And I usually recommend a higher pressure and a stiffer material. But from the beginning, if we recommend a hard and a higher pressure, usually patient cannot accept that. So I usually start low pressure with a longer stretch material and then change to the higher pressure and more stiffer material. And also I talk to the patient. Is that can be an answer?
Yeah, thank you. This question is also from Dr. Harinder Bedi. Compression at the thigh level may be difficult. Do you have any tips for the compression of thigh, the upper leg?
Thigh.
Yeah,
Actually, the thigh is, I usually do not measure the compression thigh, because if the size of the diameter become bigger, so usually naturally compression becomes sore. Probably one of the biggest problem is slip down on the elastic compression stocking. In that case, I use longer. I ask a patient to wear a longer a kind of pants, and it can connect to the compression stocking with a slippage, and that makes slippage of the compression stocking much less. But this is a very difficult question, and sometimes I use a pantyhose. I ask to use a pantyhose.
Okay, thank you. Now it's time to move to the second lecture. Thank you, Victor Kanata, for your question, and participant, and Dr. Bedi for your question. Dr. Mo, for your very nice presentation. Thank you very much.
Thank you very much.
Mr. Joe or Mr. Eric, how can you do? The second speaker is, who is the second speaker?
The second speaker would be Mrs. Professor Jin Song Wang now.
Okay. Dr. Jin Song, are you prepared? Can you start, Jin Song? Hello? Jin Song?
Hello, can you
Okay.
can you see the slides?
Okay, one moment. Okay. Now, I will introduce our second speaker, Dr. Jin Song Wang from China. Good afternoon. Anyway, good afternoon, Dr. Jin Song. I have known her for several years, and I'm amazed at her excellence and powerful activity in the field of vascular surgery. Her main work focus on the diagnosis and treatment of many kinds of arterial and venous disease. Currently, she is a vice chief of Division of Vascular Surgery in the first affiliate hospital, Sun Yat-sen University. Today, she will give us a talk about compression therapy, compression treatment after minimal invasive endovascular treatment for varicose vein. Dr. Jin Song Wang, please.
Hello, thank you, Chairman. And so during this special time, since the beginning of this year, I think like globally, people in every country are suffering from their influence by COVID-19. And this is our special chance for our Asian phlebologists to get together and to discuss the vein problem and the treatment in this special webinar conference. And I appreciate SIGVARIS to provide this chance. And after Dr. Moss' excellent talk about compression treatment for acute DVT, and I would like to talk about the compression treatment after endovenous thermal ablation of the varicose veins. And this is a small area, small field compared with the compression treatment after acute DVT. Unfortunately, there haven't been lots of random trials, clinical trials in this field. But I would like to interpret the special guidelines from Society for Vascular Surgery to focus on this small field. As we all know that our greatest venous vein insufficiency, the treatment for this has moved from open surgery to the minimal invasive treatment, endovenous ablation. And after the ablation, the physicians or vascular surgeons told the patient in different medical orders. And some, like in our hospital, even some doctors to tell the patient to wear the elastic stocking for 1 month, while the others might tell them for 7 days. And we just want to know when our Mr. Joe from SIGVARIS talked with me about the compression. So I especially put forward this question, and how long and how much pressure should we give to the patient after endovenous thermal ablation. And but the good is like there's a guideline. Actually today and my talk mainly focus on this guideline. I would say it's interpretation because it summarizes almost all literature research on this area. And our the open surgery for the greatest venous vein has been practiced for almost more than 100 years. And when we perform the open surgery, we always, like our surgical procedures told us like to give compression after the operation is finished. But why give the compression therapy? Because it's clinical experience of generations of practitioners. And our teachers told us, taught every generation you need compression. And it's not bad for patients. For the scalar therapy, we applied the compression therapy either, but that is based on experimental evidence. There's studies. And how about the endovenous thermal ablation of surface veins, like radio frequency, laser, and the microwave, and how we should give them compression? What's the rational theory of this compression, and how long and how much pressure? And we know there's a very detailed illusion explanation of this by SVS and this document. So in general, like I would like to interpret this guideline. The major goal of compression after the procedures on the greater saphenous vein or lesser saphenous vein is to maintain occlusion of the treated vein to prevent bruising and recanalization, to reduce the pain and reduce the edema after the procedure. The compression, there are different categories, and compression bandages, And this is which means with the higher compression for the bandages. It's for a handful experienced hands, like it can have 50 milli mercury on the lower leg and more than 30 millimeter mercury on the thigh. And also we have the compression stocking, which is most widely used for the patients. But this stocking is easier, but it is easier to downing and down off. And but the pressure is lower than the compression bandages. And nowadays, there's commercial self-adjustable Velcro devices for the patient, and it is more it is good for the patient to have more compliance. And there's also compression pumps and some hybrid devices like eccentric foam pads, like if after the ablation, you put a pad and on top of the vein and then give the bandage, compression bandage, or give the compression stocking. So let's see like how's the recommendation of compression therapy after this thermal ablation. European Society for Vascular Surgery suggests procedural compression is recommended after superficial venous surgery, endovenous truncal ablation, and scalar therapy. But this is a general recommendation. And for the NIH, the guideline development group, and they felt there's no strong evidence like to use or not use compression therapy. And they felt like they can't tell the people stop using stocking. And so like they gave the consensus was that in the clinical experience, some people post-surgery did feel benefit from wearing stockings. So that means from our clinical experience, compression is good, but it is lacking of very strong evidence to show we have to give the patient a compression therapy after the ablation. And but generally, most of the guidelines suggest the compression treatment. But how's the pressure? What pressure should we give to the patient after thermal ablation? Is it the same with the acute DVT, or is it the same with the PTS? And we know like the pressure in leg vein, when the patient is lying horizontally, the pressure in the vein is pretty low. And when patients stand up and in a sitting, and the pressure is much higher, it's more than 50 mm mercury on the lower leg and 30 to 40 at the thigh level. And that means like we need this pressure to occlude the vein for the compression treatment. And there's some lots of studies on the pressure level for the compression, but the most consistent findings from these studies was that patients treated with a higher level, like a moderate level, they had much less pain at 7 days compared with those treated with lower level of compression. And this study shows like, this study included 88 patients and going a variety of stripping procedures were randomized to low, moderate, and with 8 hours per day for 6 weeks. And the follow-up data were collected, and they found like at 1 week post procedures, there was less pain, tightness, discomfort, and edema in the moderate compression group compared with a low compression group. And after 6 weeks, there was no difference between different groups. But the overall quality of the published studies is inadequate because small sample size, lack of blending, lack of randomization, and the lack of data addressing compression strength and inconsistent outcomes. However, like the guidelines still can draw the conclusion post-operative pain in the first 7 days after saphenous surgery or thermal ablation can be reduced with the use of higher compression modulators and eccentric compression. And we confuse, like patients always ask, how long should I put on this stocking after I was performed with the operation? Need I still put the stocking like long term after the operation? And lots of studies on this duration, but none of the included studies was sufficiently powered or appropriately designed to definitively address the question of optimal duration of compression therapy. And this is our random trial, controlled trial, comparing compression therapy after radiofrequency ablation for the greater saphenous vein. And they are included the patients, and they treated the patient, they evaluate the patient 4 hours after compression and 72 hours after compression. And their conclusion is like wearing compression stocking for 4 hours is non-inferior in preventing leg edema as wearing compression stocking for 72 hours. So that means shorter can work too, but how short it is, or how long should, like the duration of the compression therapy, this really confused us. And this study shows like they included 111 patients undergoing laser ablation of a greater saphenous vein. And their conclusion is opposite. And they are concluded that wearing a post-operative stocking for 2 weeks after an initial 24-hour period of wearing bandages result in a small but significant reduction of post-operative pain, and compared with no wearing compression. So this gave us the idea like longer, like 2 weeks may be better. And this is a systemic review of compression following treatment of varus cause vein, and they are included several randomized clinical trials, and they found their conclusion is there's currently little quality evidence upon which to base any recommendation concerning compression following treatment for varus cause vein. So in the guideline, it is stated that it is clear that the real issue may not be compression after venous surgery, but that the compression needs to be tailored to the overall status of the venous insufficiency. That means, like in patients with only superficial venous reflux, compression may not be needed at all, or may be needed only for a short term. Whereas for patients with significant deep venous insufficiency and deep venous reflux, compression is likely to be needed not only in a post-operative period, but also long term. So that is suggested like the duration of the compression treatment after ablation is really upon the the venous system of the patient, well, not the operation alone. In our center, like we gave the patient the compression band for 3 days because the step phalangoectomy, and then change to compression stocking for 7 days at least. The patient usually have good compliance, but we found like too much pressure always can cause a skin problem, bruise, and skin damage. Too much pressure doesn't mean better. And our technician and our nurse, a lack of training of give the compression bench or how long or the pressure of the compression stocking. We need more training on the specialized nurse or technician on the compression treatment. In summary, and this guideline suggested that when possible, we suggest the compression should be used after surgical or thermal procedure to animate the various coast vein. And in compression dressing are to be used post-procedurally in patients undergoing ablation or surgical procedures on the saphenous vein. And the pressure more than 20 mm mercury together with eccentric pads placed directly over the vein might be better suggested. And in the absence of convincing evidence, and we recommend the best clinical judgment to determine the duration of compression therapy after treatment. And we need to do more further high quality random clinical trial to illustrate these questions. And we need more training on the specialist persons on compression therapy. And we need to modify the compression device and improve the quality like stocking and to make the patient to have more compliance. And this is the interpretation of the guideline. Thank you very much.
Thank you, Dr. Jin Song, for your excellent talk. Dr. Shen-Ming Wang, can you hear me? Dr. Shen-Ming Wang can talk? Should I do a polling question and the Q&A?
Yes.
Okay. Okay, ladies and gentlemen, same as previous presentation, before we open for discussion, we will conduct one polling question related to this topic. The polling question is, after thermal ablation or stripping of the saphenous vein, in the absence of convincing evidence, we recommend duration compression therapy after treatment. The number 1, best clinical adjustment. Second, 7 days. Third, 1 month. Fourth, 6 months. There are 4 possible answers as shown on the screen. So now you can choose one of them. We will give you 10 seconds for your answer for this polling question. Please enter the number of your answer on your computer screen. Now let's start. We'll give you 10 seconds. Okay, now we will close the survey. Thank you for your cooperation. Well, Dr. Jin Song?
Yes.
What is your recommendation about this answer from the audience?
I think like 7 days, I don't actually I just want to ask the people who choose 7 days, what's the evidence for the 7 days? I think most of the reason is like clinical experience, but yes, I always tell my patients, if you put on longer term, you put on stocking for longer, and it will recurrence later. I mean, like we need more evidence, like to interpret how long after the thermal ablation of the compression treatment for the, and how we educate our patient how long they need to put that on.
Dr. Mark Malov from Sydney, how do you think about this question? Mark?
Thank you. I think a lot depends on how much phlebectomy you do at the time of your thermal ablation. If it's a straight thermal ablation with little else to do, compression for a few days in a clinical sense, in a practical sense, is all you need. If you are doing a lot of additional phlebectomies, I do add a lot more and a lot longer compression to ease the bruising. I always encourage mobility, but you are right, Jin Song, the hard evidence is not there. This is a practical question on how to manage these people.
Thanks. Now, ladies and gentlemen, we will open for discussion for this topic. If there is any question or comments from participants, please send us your message with your name and your country, and then we will ask a question for you. During correction the question from the participant, I will invite the two panelists to ask a question or comments for this topic. Dr. Fuxian Zhang and Dr. Takahashi Yamaki. First, Dr. Fuxian Zhang, please.
So, thank you very much. So, Professor Jin Zhong Wang. So from US speaker have many studies. So and two questions. So now in your sitting. So how many operation in the open operation and window vascular, for example, the ablation in the syphilis rare cause vein in every year. The first question. The second question, so you, from your slide, I know, so after operation, you have the compression treatment, 3 days, 3 days have the, like the back edge, 7 days is the stocking. So this is the treatment measured to the everyone, and only you have just selected. So in my center, so after operation for the ablation, the compression stocking may be 1 month to 3 months. So I think the long time is maybe is good. So in your center is very short. So why? So 2 questions only. Thank you.
Okay, thank you, Dr. Zhang. So the first question, I don't know how many varicose vein surgery in the whole city, but in our division, like there are more than almost 400, more than 300 varicose vein surgeries like every year. And as 2 years ago, we almost stopped perform the open surgery. Like now, almost every patient undergo with their endovenous thermal ablations with radio frequency mostly, and some with microwave. And because I performed a lot of step phalanectomy, and so we have to use the much more higher pressure with the elastic banding instead of stocking in the first several days to prevent bleeding. And so the why I told the patient 7 days, and I think 7 days, I mean, it is good enough for the greater saphenous vein. I mean, after thermal ablation, they should be occluded. And there's no necessary for compression stocking to prevent the recanalization. But I grew, as I said, like I always told the patient like longer compression and later recurrence. But the patient think like I came here to have the operation like to improve my my symptoms, and why do I still need to be put on stocking after the operation? So that's why so I usually we have them on 7 days, and then they can remove the stocking based on their weightings.
Thank you.
Thanks, Dr. Jin-sung. And our second panelist, Dr. Yamaki.
Yes, yes. Thank you very much for your excellent presentation, Dr. Wang. I have one quick practical question. The role of compression therapy after and venous lasers include prevention of venous thrombosis, bruises, and pain. But compression therapy also improves the venous circulation. For this background, I think that the duration of compression therapy completely depends on the severity of venous insufficiency. Patients with venous ulcers need longer application of compression stockings after venous lasers. In my practice, patients are put on the compression stockings after venous lasers until the healing of the venous ulcers is achieved. So what is your opinion?
Yeah, I exactly agree with you. I mean, that depends on patient's pathology, and I mean, that's indeed play a very important role to determine how long the duration of the compression to different patients. I exactly agree with you.
Thank you very much.
Okay, another question? Dr. Yamaki, no question?
In Japan, most phlebologists prefer to perform venous laser combined with microphlebectomy simultaneously, as Mark said. So compression therapy is useful to prevent bruises in microphlebectomized area, I think. Is it correct?
How do you think, Jin-sung?
Yeah, like a micro. I mean, pardon your. It's a micro foam. You mean foam?
Microphlebectomy. Phlebectomy.
Oh yeah. Last step. You mean with the hook, with the step phalangotomy, right? Yes, I perform a lot, and it is if you use stocking, it can't stop the bleeding after operation. So we usually use the elastic banding to give more pressure to stop bleeding.
Okay, thank you. Dr. Jin-sung, there is a question from Dr. Wang, maybe from China. The question is, if the patient have an allergy about the bandage or stocking, how we can do for compression treatment? Is there any other method or treatment we can conduct?
What he means, the ulcer is caused by the bandage, or it is already have a venous ulcer because of the disease.
Okay.
That came.
Okay.
I mean, the ulcer is caused by the bandage or the stocking, or because the hypersensitive of the skin, or is it because of the disease itself, venous ulcer?
Okay. Any comments or any question from the audience or from another panelist?
Yes, Dr. Kim.
Okay,
May I
Dr. Mo, please. Okay.
Yes. And talking about allergy, if the patient has a nylon allergy, some of the material is covered by cotton. And so I may use for example, cotton stocking. And sometimes it resolves the allergy to the skin. And also a lot of the bandage is made of cotton, so we can use it. So there's a several material we can try on. And those kind of choice is very difficult just for the doctor. As Dr. Wong point out, the education is very important. And Dr. Wong, probably you don't have the time to teach the patient which material is good and what method is good for the patient. So I ask nurses who is qualified compression stockings. Generally they're educated and they are very motivated about compression stocking or compression bandage. I ask them to do it. So it is a very good way to do. And talking about compression period after abrasion, recently what I did is depends on if the surgery, the stripping surgery, we need more duration. And if we use a 980 nanometer laser, we need more. We have a less duration, shorter duration, the compression. So the same as compression therapy, acute DVT, I usually ask the patient, how do you feel? If the patient do not feel anything on pain on the side, I usually stop compression anymore. And acutely, we need compression definitely. The varicectomy, so usually at least 2-3 days, compression therapy is mandatory. Yeah, thank you.
Okay, thank you. Thank you, Dr. Mo, very nice comments. Okay, thank you, Jin Song, for your nice talk. We will move to the third presentation. Okay, now I will introduce our third speaker, Dr. Thomas Nopeni. He's a German vascular surgeon. He's head of Department of Vascular and Endovascular Surgery at Martha Maria Hospital, Nuremberg, Germany. He published more than 75 articles and 20 reviews to the international journal. Also, he is an author and co-author of several guidelines, such as diagnosis and therapy of varicose veins, deep vein thrombosis, and pulmonary embolism, ESVS management of chronic venous disease. Today, he will give us a talk about compression therapy for venous ulcer. Dr. Thomas, please.
Dear Professor Kim, thank you very much for your kind introduction. I hope you can see my slides. Can you see my slides?
Yes, go ahead.
Can you see my slides?
Yes.
Okay.
Yes.
So my topic of today is compression therapy for venous ulcers. And you see the data from the Bonn vein study that only 0.1% of the population who was looked at has an active venous ulcers. That means for Germany, with a population of 82 million, we have 82,000 patients with an active ulcer in Germany. The main cause of venous ulceration is ambulatory venous hypertension, as Andrew Nicolaides could show in this study. You see, the higher the venous ambulatory pressure, the higher the incidence of a venous ulcer is in these patients. One of the main causes of venous ulceration and high venous ambulatory hypertension is the post-thrombotic syndrome, and the incidence of post-thrombotic syndrome is very high. 20 to 40% of patients suffer from a PTS 1 to 2 years after a DVT. You have seen these slides as well from Dr. Mo. There are several studies that show that you can prevent post-thrombotic syndrome with compression stockings, not completely, but lowering significantly the incidence, especially in the mild to moderate post-thrombotic syndrome. And this slide you also have seen from Paolo Brandoni. He could show the same effect with compression stockings in lowering the incidence of a post-thrombotic syndrome. And then, as Dr. Mo mentioned before, the SAC study was published with the conclusion that compression stockings did not prevent PTS after first proximal DVT. Hence, our findings do not support routine wearing of ECS after DVT. But if you look at the study in detail, the study has severe flaws in design and performance. The compression stockings were sent to the patients 2 weeks or more after onset of the DVT. Fitting and teaching of the patients with their compression class 3 stockings, that means 30 to 40 millimeters of mercury, was not performed. 55% of patients who wear their stockings more than 3 days were classified as frequent users, and more than 50% could not indicate whether they have class 3 stockings or placebo stockings with 8 millimeters of mercury. So the conclusions of this study cannot be accepted as published in Lancet. What are the aims of compression therapy? We want to reduce the elevated venous pressure in the vessel and lowering venous ambulatory hypertension. We want to elevate the transmural pressure gradient to reabsorption. We want to mitigate the inflammatory reaction in the tissue. I think this is very important effect of compression therapy. And also we want not to impede arterial inflow. The effect of compression to increase the blood flow velocity, you can see in this slide, if we have a diameter of the vessel of 1.8 centimeter, we have a velocity of the blood of 0.5 centimeters per second. If we add compression to this vessel and reduce the diameter to 0.8 centimeters, we have a velocity of 2.5 centimeters per second. This is a 5-fold increase of blood flow velocity due to the effect of compression. The data from the literature show, this is a very old publication from Kevin Burnett, that compression stockings are able to reduce the effects of venous hypertension securely, even in patients with post-thrombotic syndrome. And another publication showed a significant improvement of ambulatory venous pressure in patients under compression with varicosis. The pressure was reduced 48%. And in patients with deep venous insufficiency, the pressure could be reduced by 18%. We have different compression tools, as you saw before, elastic fabrics and stockings, and inelastic fabrics. First, I want to talk about compression bandages. Compression therapy normally is exercised in 2 phases. First, reducing the edema. Second, to keep the leg thin. The dressing technique should be fast and easy. The dressing should be not too tight because this causes pain and is not tolerated. The effect of a good applied dressing comes fast. Therefore, the dressing loosens and has to be changed on a daily basis. The dressing should be comfortable and should not slip. So the ideal tool for bandages are short thread bandages. They have a low resting pressure, so they are very comfortable for the patients and have a high working pressure so that the edema can be reduced during walking very fast. But you see in this study, you see the disadvantages of compression therapy. Kerstin Protz is a German nurse working in the University Hospital of Hamburg, and she performed a study in Germany with more than 890 care providers. These were 3.3% physicians, 5.5% medical assistants, and approximately 91% nursing staff to test the knowledge and expertise in bandaging. The test person should reach a pressure of 40 to 50 mercury under the short thread bandages. And you see only a minority of 6 to 7% achieved this desired pressure. A significant part the pressure was too high, and also in other significant parts, the pressure was too low. And they measured also the pressure after moving of the patient. And you see a significant drop of pressure just after 1 foot movement. So these are the disadvantages of bandage therapy. The next compression tool are compression stockings. So you see the different compression classes. Normally for venous ulceration, compression class 3 is applied. And this has a strong effect of the superficial and a moderate effect of the deep venous system. The success of compression therapy depends mainly on the compliance of the patient. The compliance is high if the success is fast and visible, if the patient is good informed and understands the principles, if the physician has a good expertise, and if the stockings are comfortable. So there are special ulcer stocking kits designed for patients with chronic ulcerations, and some small studies show that these ulcer kits have a better effect on the ulcer healing in patients than other devices. But some disadvantages of the stockings you can see as well. False measurement, the stockings are too long or doesn't fit at the thigh or the knee, or mistakes in putting on the stockings, as you can see in this slide. The compliance wearing stockings and recurrence of ulceration was studied in this study. You see if the compliance wearing stockings is very good, the recurrence rate in this study was only 4%. If the compliance is bad, that means that the patients are wearing the stockings 2 to 3 days a week. The recurrence rate was 39%. And if the compliance, if there is no compliance wearing the stockings, the recurrence rate of ulceration was 57%. So we look finally to inelastic fabrics. There is a Cochrane review from 2012 that shows that patients with 4-layer bandages showed faster healing than patients with short stretch bandages in chronic ulceration. And we have now so-called Velcro devices. These are inelastic compression devices. The one of great advantages is that self-management is possible. Rapid reduction of edema could be achieved. The compression and the compression pressure can be readjusted, and therefore they are very cost effective. So we have, SIGVARIS also provides such a Velcro device, as you can see here in this slide. And I got some data from my friend Giovanni Mosti. He had performed a case series with 20 patients affected by venous ulcers. Ulcer surface varied between 5 to 50 square centimeters, ulcer duration 6 months to 1 year. The compression pressure applied was 50 to 60 millimeters of mercury. The patients were educated to readjust their compression pressure when looseness sensation occurred. 17 out of 20 patients healed, 3 are improving. 14 of 17 healed within 3 months, quite very fast. You see one example of his patients with this ulceration. And you see after 7 months and 17 days, this ulcer healed completely under Velcro application of Velcro devices. We have some studies to these Velcro devices. One study published in 2016 say that Velcro compression wrap may provide a simple, clinically effective and patient acceptable solution for self-care with compression. Remember that patients with short stretch bandages should be readjusted on a daily basis in our daily practice. This is combined with very high costs. And these devices have the potential to reduce the overall healthcare burden by reducing necessary skilled treatment visits and or costs while still achieving good clinical outcomes. And Hugo Parch published also a review article about Velcro devices and concluded that it is shown that stiff, non-yielding material applied with adequate pressure provides hemodynamically superior effects compared to elastic material. And in our European guideline, we concluded as well with this recommendation, compression therapy, despite significant improvements in dressing materials and other methods, remains a cornerstone of conservative treatment. This is because of its ease of use, non-invasive nature, and also efficacy in managing venous hypertension, the main pathophysiological mechanism of chronic venous disease. So in summary, compression with inelastic fabrics are superior to short stretch bandages, but you have to take into account that you have a complete treatment concept for chronic ulceration. The basic is compression. It should be added by wound care, wound and skin care. You have to treat superficial venous reflux if you find any of this. You have to think about surgery of ulceration, for example, shaving, if you cannot achieve ulcer healing within 3 months or longer. And you also can think about surgical or interventional treatment of deep venous reflux or obstruction in post-thrombotic patients. As you can see here, an example by my friend Lefeng Chu from Shanghai. Complete occlusion of the left iliac vein, and this is the picture after recanalization of this deep venous occlusion. So thank you very much for your attention.
Okay, thank you, Dr. Thomas, for your nice talk. Okay, one moment. Okay, ladies and gentlemen, there is one polling question. Please show us the polling question. Mr. Jidan. Okay, the polling question is, inelastic compression device are superior to short stretch bandage in compression therapy of chronic ulceration. Please click the circle, yes or no. We'll give you 10 seconds. Now, start. Okay, now we will close the survey. Thanks for your cooperation. See that? Okay, the majority.
So just one comment to this very easy question. So this represents only our own experiences with these Velcro devices. We have made very good experiences in patients with venous ulceration applying Velcro devices.
Okay. Now, ladies and gentlemen, we will open for discussion for this topic. If there is any question or comments from participants, please send us a message with your name and your country, and then we will ask a question for you. During correction the question from the participant, I will invite 2 panelists to ask a question and comments. Dr. Jang Yong Kim and Dr. Mark Marlov. First, Dr. Jang Yong Kim, please go ahead.
Thank you for nice presentations about the compression therapy for the venous ulcers. I saw so many different options for treat the venous ulcer, like venous ulcer stockings or elastic compression therapy like a Beccolo, or shaving techniques, or endovascular or surgical treatment for the revascularizations. I saw many disagreement for the gold standard or guidelines for treatment of venous ulcers. What is current guidelines in the Europe to treat the chronic venous ulcers as a article based. And in my opinions, many doctors recommend the multi-layer compression therapy for the primary treatment. What is your opinions about the guidelines wise treatment?
Yeah, our concept is basic with inelastic devices, for example, multi-layer devices or Velcro devices. And then if we find, in addition, some superficial reflux, you have to ablate these superficial reflux. There are very good studies published. And only if you cannot achieve ulcer healing for a very, very long time under consequent compression, then you can think about, for example, shaving therapy or recanalization of the deep venous system. The indication for recanalization of the deep venous system is very, very difficult. So you have to think very carefully applying this to the patient, and it's very hard to select the right patients for this treatment.
And my second question is the wound in from the venous ulcer. There is many discharge, and how can you handle the discharge, the dressing method? Do you have any special tool to control the discharge?
Yeah, I think you can add some wound dressings which suck the fluids. Mm-hmm. And if you apply consequent compression and reduce the edema, then the expression of fluids is lowering and lowering, so that you don't need that you don't have this markable fluid.
Do you think the back dressings, the negative pressure dressing, is working for the discharge for the venous ulcer?
I think the Velcro devices are working because you can apply the ideal pressure between 50 to 60 millimeters of mercury, which you normally cannot achieve with compression stockings. And normally you can also not achieve with short stretch bandages, as I showed you in the study from Kerstin Potts. So I think the invention of inelastic devices are a major step forward in the therapy of chronic venous ulceration.
Thanks, Dr. Zhang Yonggim. And next, Dr. Mark Malop, please.
Thomas, that was a great presentation with a clear message, and thank you for that. In my ulcer clinic, we are still doing 2-layer low stretch bandages for compression. We went to stocking kits and we didn't like them, and we came back to bandages. Now we are tempted to try the Velcro, the Compriflex, which I think the SIGVARIS product is the best Velcro on the market. And we are tempted to do that. Is this a good idea? We should convert from 2-layer compression to the Compriflex to give it a trial. Have you done that?
Mark, I think this is a good idea because even in our experiences, the Velcro devices are superior to short stretch bandages, but sometimes it depends on the reimbursement system in the country you are living for. So, so in Germany, the application of Velcro devices, the insurance companies has to admit that we can use this. And sometimes they don't, they say, no, they don't admit this because it's too expensive.
Okay,
so
thank you.
This is a problem.
And second question to follow up on Zhang Yong about the vacuum assisted compression, the VAC device. Have you managed to be able to combine a VAC device with good compression? Because this, from a physical point of view, is difficult, and to encourage mobilization. So can you put a VAC, a compression, and get them to walk?
We don't have experience in this concept of therapy. We apply VAC devices in ulcers with fibrin and where bacteria is on the surface to clean the ulcer and then apply compression afterwards. But we don't have experience with the combination of VAC and compression.
Okay, thanks.
Thank you, Thomas and Dr. Mark. Dr. Thomas, there is a question from the audience from Dr. Wang. You know, we have several types of stocking, below knee type or thigh type. His question is there any ideal standard selection for the patient who need compression? Does it depend on the location of a venous region? How do you think?
Yeah, venous ulcers normally are located at the calf, and we treat venous ulcer patients with calf stockings or with Velcro devices applied at the calf. I think this is completely sufficient because due to the physics of stockings, you have the maximum pressure at the ankle region, and the pressure at the thigh is only 20 to 30% of the pressure in the ankle region, that you exercise not much compression at the thigh in these thigh long compression stockings. So therefore we use only calf stockings or calf Velcro devices in treatment of chronic ulceration patients.
Okay, thank you. Mr. Jidan, there is some message from Malay Patel from India. He wants to give us some question or comment. So would you please connect to the Dr. Malay Patel, Mr. Jidan? Mr. Jidan, can you hear me? Eric?
Mr. Khaled, can you give the microphone to Malay, please, to Professor Patel?
Yeah, I got it.
Good.
Can you hear me? Yeah.
Okay, okay, Malay.
Yes.
Okay, go ahead.
Just 2 days ago, I received this. Can you see me? Can you see my video?
No.
No, we cannot see you.
But we can hear you. Go ahead.
It's okay.
I received this leg sleeve from SIGVARIS, and they have kept a promise of giving me a leg sleeve that we can try for patients in warm countries where compliance has been poor. So I just wonder if anyone else from the warmer areas or from China or somebody has had a similar experience, or is this going to be a very new thing that we are going to look at?
Thomas? The SIGVARIS, the manager of SIGVARIS?
I don't know this device.
I think it's basically a sleeve. It's a stocking without the foot part. And I think in January, Malay asked me whether we could do something for him because he felt that this could be a good kit or a good device in hot countries. Mm-hmm. So we have come up with something, and I think you must have seen those because we sent it to India to start a trial there. I think the idea is also very common in Korea, where many nurses actually have the sleeve because they feel much more comfortable during work. So this is as far as we are. We are in the developing phase, and we have asked Malay to have a look at it and trial it out.
Yes, that's what I'm trying to hint at, that this could be also something that may come along, because the Velcro devices are a definite advance. It's the future, I think. But the problem right now is our patients like to put on something and which is less expensive, and yet we still want them to be compliant. So I think this leg sleeve may work out. So let us hope for that.
Okay.
Thank you. That's my
Thank
comment.
you.
and question.
Thank you, Dr. Emmanuel Patel. Thomas?
Thank you.
Okay, Dr. Thomas,
Hmm?
one more question from the audience is, would you please explain about two-layer stretch bandage versus four-layer stretch bandage in venous leg ulcer?
Two-layer stretch bandages are wraps, and four-layer bandages are something like a Velcro device. So this is completely different.
Okay. This question is from the Edwin Stepan. Is there any comments or question from all of the panelists? No? No comment or no question?
Professor Kim,
Yeah.
Giovanni Mosti, whom we all know, raised the idea of inverted compression so that you get a little bit more compression in the middle of the calf, and that might be the principle of this sleeve, which is good. As you know, Giovanni Mosti, as well as Thomas Knopp and I, are the masters of compression, and this might have a good future. This sleeve.
Okay, thank you.
But Mark, nobody knows actually. So I think exercise, high compression with 50 to 60 millimeters of mercury at the calf, this is the best compression option for venous ulceration. And so.
Okay, Mr. Jidan, can you connect our microphone to the Dr. Victor Canata, Paraguay? Can you connect us? Eric, can you help us?
Yeah. Mr. Khaled, can you open the microphone?
To the Victor Canata, Paraguay.
Mr. Khaled?
Hello.
Hello.
Yeah, hi. This is Harinder Singh Bedi from India. Can I get into while the other speaker connects? Can you hear me?
Okay.
Yes.
Okay.
Yeah.
Go
Hi.
ahead.
Very good morning. Good afternoon, depending on where you are. And it's a pleasure to see so many pioneers and so many friends, especially Dr. Malouf and Dr. Kim, whom I know very well. And excellent talks by Dr. Wang, Dr. Mo, and Dr. Thomas. My question is to Dr. Thomas. At what stage would you say my compression is not working and I would like to intervene? For example, the EVRA trial showed us that if there is a venous reflux, especially if there's a perforator at the base of the ulcer, then it may be a better idea to, within a short time, to treat that rather than just to continue with compression. So my question is, when do you say, okay, compression is not working? 1 week, 2 weeks, 3 months?
I think it depends on the clinical findings of the patient. If you find a superficial reflux, you should eliminate this reflux as short as possible. That improves the venous hemodynamics and is lowering the venous ambulatory hypertension. So this is our concept, but this is not an alternative in chronic venous ulceration to compression therapy. You need both. You need elimination of the venous reflux and compression therapy, even after the ulcer has healed. And especially, for example, in post-thrombotic patients, we then measure after healing of the ulcer the venous outflow. And if the venous outflow is reduced significantly on the affected leg, then we recommend the patient to the patient that they wear compression on a continuous basis.
Thank you.
Okay, thank you. Dr. Victor Canata, can you hear me?
Yes, yes,
Okay.
I'm hearing you very well.
Okay.
Thanks,
Okay. Go ahead.
Thanks, Dr. Kim, for this beautiful webinar. I think this is the way that we have to move from now on, since we have that COVID issues. This is the way that we have joined together. Dr. Makoto was talking about some kind of, Dr. Mo was talking about the way that he's handling the compliance. And this is the question that I would like to address to everybody else. Because the patient, since we're putting on the bandage, the only thing, and the stockings, the only thing they want to hear is after when I will use my stockings. How do you follow up the compliance, and what will be the future after they use the bandage? Because when I talk at the bandage and the stocking, there's still some swelling regarding about the leg, and the patient complain after this. The question is how you address the compliance, how and what after the follow-up when you took the stockings off, what are you do to prevent the swelling of the leg?
Okay. Dr. Kanata, question to Dr. Mo or Dr. Thomas? Question to whom?
Yeah, but for Dr. Mo or Dr. Thomas, both of them.
Both of them. Dr. Mo, can you hear me?
You switch.
Yes, I can hear you. So question is a compression bandage and a compression bandage and a compression stocking, when you have to change, or is that question? Or
yes,
the compliance?
Yes, this is the question.
Yeah, basically, I usually, if the patient has ulcer, I usually start with a bandage because with compression stocking, it's very difficult to change dressing. And most of the patients, even though we use a two-layer compression stocking, the base layer is still very tough to put on a compression bandage, compression dressing. So I usually start with a compression bandage first. And then if the wound becomes very small and the compression becomes small or cured, I change to the compression stocking. And at first I use, for the maintenance, I use a little higher pressure, 30 to 40, until completely cured. But usually patients complain a lot after ulcer becomes more cured and the skin becomes much better and softer. I usually change to the 20. And the length of the stocking is, at first we might use a thigh high, but change to the knee high stocking because it's more convenient. And sometimes we use a softer compression stocking instead of stiffer compression stocking because it is easy to wear. Am I answering your question?
Yes, thank you very much.
Okay, everybody, thanks. Now, ladies and gentlemen, it's time to close today's webinar. It's already 2 hours from the starting. As I'm a moderator today, first of all, congratulations on successful organization for today's webinar by SIGVARIS Group Asian Pacific Edition. Especially, I would like to give my big thanks to Mr. Eric Cutter and Jian Zhou, manager of SIGVARIS Group, for giving us such a wonderful academic meeting. And also thanks to all of the speakers and the panelists for their efforts. I hope today's webinar will be a great help to all of us. Thanks. Now, SIGVARIS Mr. Jia Zhou will wrap up today's event. Mr. Jia Zhou, please.
Okay. Dear all, thank you very much for the successful scientific event. Our thanks especially to our moderators, speakers, and panelists. You have spent a lot of time for the preparation. Even you are so busy as a work, all the time. We very happy, and also we will continue this webinar platform, and also we would like to invite you all to the physical congress and the seminar. Our first physical session, lunch session on 23rd of October in Seoul at the RSVS from 21st to 24 October in Seoul. You are all welcome. Join us. We work together, make great cooperation for our patient, for our treatment. Thank you again. Have a nice weekend. Thanks. Bye-bye.
Thank you to all of you. And
thanks all of
Yes.
you.
Bye-bye.
Yeah, bye-bye.
Thanks.
Thank you very much.
Yes,
Thanks,
thank you.
Eric.
All the best.